Friday, February 16th, 2018. We're ripping through the new year here. So got a great action-packed program tonight. We're going to talk about surgical treatment of cardiac disease with Dr. Neil Galindez, cardiothoracic surgeon with Tenet Florida Physician Services and on staff at Florida Medical Center, campus in North Shore in Fort Lauderdale. You're familiar with that hospital. We've had the CEO, Trey Abshire, from Florida Medical Center on the program. A lot of orthopedic surgeons and physicians, endocrinologists from Florida Medical Center. So we're happy to have another doctor from their great hospital back on the program. So I don't want to waste too much time because we're going to get right into it. Dr. Galindez, welcome to the program. How are you doing?
Very good, David. Thank you for inviting me again.
Thank you for coming aboard. I mean, we're always talking about health, and we like to get, anytime we can get a cardiothoracic surgeon in the studio, that is just fantastic because you do great work, and I know you're doing a lot of minimally invasive stuff. So let's get right into it. I just came in contact with this term recently. I don't know if that's the right word, contact, but I was just reading up on it. CABG surgery CABG is the acronym CABG. I know it's a bypass surgery. What actually is it, and when is it needed for the heart?
So CABG stands for coronary artery bypass graft surgery. Okay, and this is a procedure that we do when the coronaries, which are the arteries that feed the heart, get occluded either by plaque or by a thrombus or for any other reason. Okay, let me talk to you about atherosclerosis first, so we can get have a good idea of what we're talking about. Atherosclerosis means just sclerosis of the arteries, any arteries in your heart, in your body. Sclerosis means hardening, and we know that some of us have factors that predispose our bodies and our arteries to get occlusions, to get hard, to get low flow through those arteries, either in the legs, in the arms, in the brain, the heart. They're not different. Okay, so when you do have atherosclerosis, especially in the heart, you're gonna have over time some problems with flow. The blood flow that was supposed to go nicely and easy through those arteries to feed the muscle of the heart. Over time, you have one of those lesions or occlusions in the arteries is going to start getting lower and lower and lower. The flow is going to suffer, and then the heart area beyond that portion of the artery will get less blood and less blood and less blood until one day the blood flow is so low that it can cause an injury to the actual muscle of the heart, and that's what we call a heart attack. When we have an actual injury to the cells of the muscle of the heart, that's when we are going to see things like chest pain, chest pressure, shortness of breath. The patients go to the hospital. The first thing to do for the emergency physicians are to find out what's going on with the patient, right? Mm-hmm. So they're going to start the emergency workup, which is going to include an electrocardiogram. An electrocardiogram is a trace of the electrical impulse of the heart. And we know how it's supposed to look in a normal heart. In a heart that has an occlusion, an artery that has an occlusion in the heart. And when that piece of muscle has an injury, the tracing on that EKG or electrocardiogram changes. And that's one of the things, the first things that we notice when the patient gets to the ER having chest pain or shortness of breath. Also, the workup includes lab work. Mm-hmm. The muscle is going to spill certain enzymes, cardiac enzymes, into the circulation if there's injury. And we can detect those on the lab work. So if you have chest pain, chest pressure, shortness of breath, lightheadedness, cooling, clammy skin, right? Mm-hmm. And you get to the ER and your EKG is abnormal, and then you have elevated cardiac enzymes, that's an indication that the patient might be having a heart attack. So the patient is going to be taken immediately to the catheterization lab, where a cardiologist that specializes in procedures will put a special catheter through the groin, shoot some special dye, and under fluoroscopy, which is a special X-ray, we can see the coronaries, which are the arteries that feed the heart. If you have blockages, the cardiologist will detect those blockages and can do something about it. Now, it could be that the patient has only one blockage, and that's why it's having the symptoms, and that can be opened up with a special catheter with a balloon on the tip, and they can balloon up that vessel to open it up and reestablish the flow.
Angioplasty?
Angioplasty.
I read about it today.
That's
I was
right.
doing my research.
So, second, the patient might need a little more than that. If the occlusion is really narrow, the cardiologist can put a small catheter through that narrowing, through that occlusion, and actually deploy a little mesh in the form of a tube, which is called a stent. That's right. And that stent has radial force, and it will push all the plaque inside that vessel to the outside, and it will open and reestablish the flow of that coronary, so the blood flow will continue going distally to that occlusion, and now the heart, the muscle that was affected by the lack of flow will get new flow and will get better.
That is a fantastic representation of what's going on with the heart. And I liked how you mentioned about the enzymes, because I know that's something that is tested early on, or when there's an emergency with the heart like that. There's definitely a blood test done early, and then yourself and the cardiologist, your team, your cardiac team, are reading and seeing certain flags, like enzymes, that are telling you exactly what's maybe going on with the heart. You can start prepare the next stage of treatment. So that is just amazing where medicine's going.
That's correct. And as I said, once the patient hits the ER door, the clock starts ticking. And we know that we have certain time to get this patient, if the patient is having a heart attack or a coronary occlusion, to get to reestablish that flow, because time is muscle. Okay? If we don't open that artery quick enough, the muscle will start dying. And then the patient will have a full myocardial infarction or a heart attack. And this can predispose the patient to have arrhythmias or even sudden death. So we know that time is of essence. Now, when the cardiologist takes the patient to the cath lab and the patient has multiple arteries affected by these narrowings, by this plaque, then the cardiologist will call the cardiac surgeon to alert him, to make sure that he knows about this patient, because we know that patients that have what we call multiple vessel disease, this means more than one artery, right? Multiple occlusions and multiple main arteries of the heart, patients need surgery. When you compare patients with this kind of disease, coronary artery disease, multi-vessel coronary artery disease, with the patients that are treated with stents or with the ballooning, compared to those that are treated with surgery, patients that are treated with surgery tend to do better at a long term. So we know that a patient with multi-vessel disease, coronary artery disease, it should be a candidate for surgery.
Okay, and that's the cabbage surgery when you have to bypass certain blockages. That's what's going on there then?
That's correct, and that's why it's called bypass. What we essentially do as surgeons is take the patient to the operating room. The patient goes under anesthesia, and then we connect the patient to the heart and lung machine. This is a machine that will circulate the blood and will oxygenate the blood and will take over the function of the heart and the lungs during the surgery, so we can stop the heart and work on the arteries of the heart. Now, what we do is we use arteries that run along the inside of our chest wall, in the front of our chest. There's two arteries. We usually take the left side, and if the patient is a candidate to use both sides, then we take those two arteries, and we use those arteries to plug them beyond the point of occlusion on the heart. So now, because you had an occlusion of blood, of oxygenated blood through that coronary, right? Now the blood is going to go through the new artery that we plugged, bypassing the occlusion, reestablishing the flow into the affected segment of muscle of the heart. And that's how we reestablish the flow. Now we use arteries and we use veins. Sometimes we get veins, pieces of vein from the leg to do exactly the same thing. We plug the vein proximally from the main vessel coming out of the heart, of the left side of the heart, which is the aorta. Okay, we make a small hole, plug, and sew the vein there, and then bypass the occlusion on the coronary and plug the vein beyond that point. So now the blood flow is reestablished by allowing blood going from the aorta through the vein, bypassing the occlusion, and beyond the occlusion, going into the coronary artery. And now that segment of heart muscle that was affected by the occlusion is going to have new reestablished flow.
That's just amazing description. I just have two questions. They're really quick questions because I want to get into the other stuff. How big is the normal human heart? Is it? Is there a way of saying it's my size versus your size, or are they all the same size? How does that work?
It varies with the size of the patient. Usually, if you make a fist, right, it's kind of the normal size of a human heart.
Oh, wow.
Women tend to have a smaller heart sometimes, but we know that certain conditions affect the size of the heart just because of the variation in pressure in the chambers and the strength of the contraction. Sometimes with certain disease processes as heart failure, the function of the heart and the strength of the muscle is so low that the heart will start dilating or getting bigger and bigger and bigger. You have patients with very, very big hearts, but those are disease hearts. They are not normal hearts.
Yeah, that's when it's inflamed, and that's a whole nother story as well. And then the other question I want to ask really quick before I get to the next topic is, for the CABG surgery, is that something that is now done minimally invasively, or is that something that it still requires? Is it the sternectomy?
A sternotomy just means that you make an incision in the breastbone, right, the breastbone of your chest, right in the midline, and then you, with a special retractor, you open you pull the two halves apart so you can have access to a heart. Probably 99% of centers in the U.S. Do this procedure. Now, there's some places where they do kind of a hybrid procedure where the cardiologist will place stents in the less important vessels in the heart, and then you take the patient to the OR, and with minimally invasive techniques, they do the main graft to the main coronary artery, which would be what we call the LAD. And you plug the artery from the chest that I just mentioned into that LAD, and that's probably the main and the most important graft that you're going to have in a patient. And you can do this minimal invasive if, the cardiologist already placed stents on the other blockages.
Dr. Galindez, hold that thought. We're going to take a quick commercial break, and on the other side, talk about heart valve surgery and an amazing procedure you're doing for AFib, atrial fibrillation, on the How to Stay Healthy show. How to stay healthy. It's a question asked by many people and answered by few. On How to Stay Healthy with David DePino, I'm going to bring you the latest in health news by interviewing top doctors from South Florida and around the world. Tune in on Fridays at 5:30 p.m. right here on WWNN Radio 95.3 FM and 1470 AM, the Health and Wealth Network, to hear the latest health treatments and my curveball question of the hobbies and passions in life doctors pursue when not providing medicine.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096.
And now back to How to Stay Healthy, your weekly doctor's interview and prescription to better health. Welcome back, South Florida. We're here with Dr. Neil Galindez, cardiothoracic surgeon with Tenet Florida Physician Services in Fort Lauderdale. You can actually put his website right into your URL, drneilgalindez.com. You can find out more. We're talking surgical treatment of cardiac disease. We just talked a lot about the CABG surgery, the bypass surgery. I want to get into heart valve surgery. You perform heart valve surgery now. Tell us a little bit about that on the back end of that. Is that minimally invasive heart surgery?
So let's talk about valvular disease. The heart has 4 valves. Okay, these valves are meant to allow blood flow from one chamber to the next only in one way. If you have a malfunction of the valve, that valve is going to be leaking blood the opposite way. And as you might imagine, then that's not going to be an efficient system, right? So if you think of the heart like a square and you divide that square in 4 equal squares, the top squares are going to be the top chambers, which are the atria, the left and right atrium, and on the bottom side, the bottom 2 chambers are going to be the ventricles. There's on the right side of the heart, there's a valve that allows blood from the right atrium to the left atrium. On the left side of the heart, there's a valve that allows blood from the left atrium to the left ventricle. Okay, let me correct myself because at the beginning I said left atrium to the right atrium. It's from the blood flows from the atrium to the ventricles. Okay. Now, on the left side you have the mitral valve that allows that to happen, and on the right side you have the tricuspid valve. Now, when the ventricles, which are the bottom chambers of the heart, squeeze that blood out to the lungs and to the rest of the body, right? The right side squeezes that blood through a valve called the pulmonic valve. That goes to the pulmonary artery into the lungs for the blood to get oxygenated. That blood goes back into the heart to the left atrium, then through what we said it was the mitral valve into the left ventricle. The left ventricle squeezes that blood now through another valve, which is the aortic valve, that is going to go through the aorta and to the rest of the body. Okay, so we have 4 valves. On the left side, we have the mitral valve and the aortic valve. On the right side, we have the tricuspid valve and the pulmonic valve. And these valves can get affected for many, many, many reasons. Okay, one of the most common valvular disease that we see in the hospital is something called aortic stenosis. Okay, stenosis means narrowing, just narrowing. And if I'm saying aortic stenosis, means that the aortic valve is affected in a way that instead of opening and closing nicely, now it's going to be very narrow and it's not going to allow blood to flow normally. Okay, and this happens because conditions like diabetes, hypertension, cigarette smoking, and just genetic predisposition and age. Okay, with time, some of us will get some of that stenosis. Now, the disease is of various degrees. It starts as a mild process. It progresses into a moderate and to severe stenosis. Many patients are treated medically through many, many, many years when they're at the mild, moderate, and even sometimes the severe stages of the disease. Once the patient has a severe stenosis or severe narrowing of the valve, that means that the valve is thickened, is not opening well, is not letting that blood flow the way it's supposed to, and the ventricle, the left ventricle, has to work really, really hard to eject that blood to the rest of the body because it has to go through the valve, and the valve is closed, right?
Right.
So when the patient develops severe aortic stenosis and develops symptoms like chest pains, like dizziness, fainting, like heart failure. Those are the main symptoms of aortic stenosis. When the patients develop those symptoms, we know that we're at a point where we need to do something about the valve. And in fact, if you take the whole population of patients with symptomatic aortic stenosis, okay, and you don't do anything about it, you just watch them, half of those patients will die because of the aortic stenosis in about 2 years. Half of them. So it's a deadly disease. And unfortunately, there's nothing medically we can do to reverse that process. There's no medication, there's no exercise, there's no diet that you can follow to clean up that valve and let the valve start working the way it's supposed to be. The only thing that you can do is physically remove the valve and put a new valve in. And that's what's called aortic valve surgery. So the gold standard is by placing the patient, again, connect the patient back to the heart and lung machine, arrest the heart, open the aorta, and look at the valve, physically remove that valve, and implant another valve. It could be a mechanical valve, which is made out of plastic and metal, but the patient has to be on blood thinners for life. Because it's a foreign object, it tends to get clots. And if it gets clots, the hinges of the new leaflets, the new valve, will malfunction, and the valve can get stuck open or closed, and that creates a problem. So the patient needs anticoagulation for life. The other kind of valves that we have are tissue valves, what we call tissue valves. And these are made out of animal tissue. They're made out of the pericardium, which is the sac around the heart of cows and pigs. And the companies make these valves, and they sew them by hand and create a very similar valve that what we have naturally. And they mount those leaflets or those little doors into a ring, and that's what's implanted in the patient. Now, the advantages of this valve is that the patient does not have to be on anticoagulation for life, because it's made out of tissue, and but they tend to last a little less than the mechanical valve.
I've heard that. That's mesmerizing description about heart valves. Lastly, I know we have, I think, about 4 minutes, so let's get into a little bit about AFib, because we hear it all in the news, and I know you were in an amazing trial recently, the SubX, and correct me if I'm wrong, subxiphoid approach hybrid ablation case in the Converge International Clinical Trial, and that was with a cardiac electrophysiologist, Dr. Matthew Klein, and yourself. Tell us a little bit about the SubX approach, and start with, I guess, how you access the heart from the outside.
So,
Did I get that right?
Yes. So what you're talking about is atrial fibrillation in the Converge trial, which is an international trial that is trying to establish the efficacy and the results of doing a hybrid ablation versus a catheter ablation for patients with atrial fibrillation. And atrial fibrillation, again, put in your mind and picture this square with 4 squares inside. The 2 squares on the top are the atrium, and when the atrium are instead of contracting with each heartbeat to send that blood to the lower chambers of the heart, which are the ventricles, on atrial fibrillation the electrical impulses are abnormal. So there's a lot of misfirings and that create an erratic and uncoordinated contraction of the atria. And when the left and the right atrium are instead of contracting, they're just quiver. And if you can see the actual heart, and we see this very often when we do heart surgery, instead of the atria contracting, they're just quivering. That's atrial fibrillation. So patients are at increased risk for having a stroke, 5-fold actually risk compared to someone that does not have atrial fibrillation, 3 times fold higher risk of having developing heart failure. And the mortality is always higher with patients with atrial fibrillation. So it's really important that us as surgeons, when we have a patient, let's say that we're going to take for CABG, that we talk about CABG, right, for bypass, and the patient has atrial fibrillation, we need to address the atrial fibrillation because that's probably the only opportunity that we will have to treat that patient. And we can do certain ablations. Ablation is just burning of tissue, trying to create lines of blockage for that abnormal impulses and trying to reestablish normal contractions. That's done for open heart surgery. Now, in the trial, we're doing a hybrid ablation. That means that with minimal invasive techniques, the surgeon goes from the outside of the heart and creates those lines of blockage, trying to block all those abnormal impulses for atrial fibrillation. And at the same time, the electrophysiologist goes with a catheter through the groin inside the heart to try to complete that ablation. Then the patient is going to be seen in the electrophysiology lab, where we can create a 3D image of the atrium, and we can see actually what's still firing, and with the catheter just terminate that ablation. The results are better. The trial is ongoing, and we were the first ones, in the international trial that did this through a subcipher approach. Before, we used to go through the abdomen. Now we have to do a small incision right below the sternum, the breastbone, and without going through the abdomen, do this ablation.
That's just amazing to me, and thank you for the great teamwork between you and your Tenet Florida Physician Services colleagues, Dr. Klein, the cardiac electrophysiologist. Hard to believe we ripped through 30 minutes, but I just want to thank you again for coming on the program. It is February, is American Heart Month, and to have a cardiothoracic surgeon in the studio here talking to us about the heart and cardiac disease is just amazing. Thank you again, and always welcome to come back on the program.
Thank you, David. It was amazing. Thank you.
It was. Thank you. And join us again next Friday on the How to Stay Healthy show. For a prescription to better health from the top doctors in the medical fields of cardiology, neurology, orthopedics, sports medicine, and primary care, join us each week on the How to Stay